Hello everyone, welcome to another episode of Inside the Studio. My name is Kartik Valluri. I am a cardiovascular critical care physician here at Baylor St. Luke's, THI, and I will be speaking with Dr. Carson, who has given us grand rounds today regarding blood components and how low the threshold can go. In the aftermath of your talk, what I got from it was pretty much multiple trials have been conducted regarding blood transfusion thresholds. There are multiple recommendations, and there's a lot more data that we still need in specific subgroups. When it comes to cardiovascular critical care, I have patients who have acute MIs, which I know is significant with the MINT trial, and I have patients who are post-cardiotomy, whichever cabbages or whatever, which might require more. And one of the things that you said in the middle part of your thing, and you said it's the most important slide, is the clinical context. Can you explain that to me in a little bit more detail?
So look, these trials were designed with two thresholds usually. And you know, are those numbers the perfect numbers? I don't know, but that's what the trials were designed to evaluate. It's likely that your individual patient has unique physiology, unique underlying comorbidity, maybe doesn't want blood or would be happy to take blood. So individualizing your treatment makes clinical common sense, and that's why we always emphasize that. Having said that, I don't have evidence to tell you exactly how to do that. You know, should you weigh the blood pressure? Should you weigh the pulse? You know, in acute MI patients, what about the cath results and what's vascularized and what's unvascularized? I mean, those are all variables that you would clinically make it would be common sense that you would consider in your decision making. I don't know exactly how to weigh those things, but I think in the end, so much of what we do in clinical practice is we don't have perfect data for sure, and that you try to take the average effects that you see in these trials and then apply it to your individual patient and adjust what you do based on that patient's unique situation.
Great, thank you. But you know, since training, since residency, not myself in general, the culture is that restricted. Keep it, only when we hit the 7 mark do you give it. But today's talk was that you see there's more of a shift more toward a liberal aspect to these transfusion thresholds. Can you explain for a confused clinician?
There's new data.
What do you do?
There's new data. So, you know, like all the data up to this point said less is fine, okay? And now there's new data in acute MI, and there's new data in neurocritical care patients as well. There's 3 big trials, 2 in New England, 1 in JAMA, and they trend towards more blood, liberal being helpful in that group. So, you know, research advances our knowledge, and we need to keep our best, we need to try as hard as we can to keep up with the latest information and then adjust what we're doing. And I think in your unit where you have cardiac surgery patients and you have acute MI patients, it means you have to look at your individual cases, what their underlying diseases, and the data that applies to each of that subgroup of patients is different. And so, you know, it's not always easy to have just one number. I'm afraid that in this particular field, as we accumulate a lot of trial evidence, that, you know, that we have to refine our approaches. And so it's challenging. It's challenging. You know, I'm interested in this. You're interested in this. But clinicians who have no special interest to know these nuances is hard. And it's up to us to try to teach them about it.
Okay, but we live in a world where everything's protocol, right? We're pushed from a more of a national standpoint from the corporations and the hospital systems to limit our transfusion rate. But you said the difference between liberal strategy and restrictive strategy. What's the non-inferiority aspect of it? Why don't we just stick to the restrictive?
Well, at least in acute MI, patients live longer and have less recurrent MIs. That's a good reason. Look, you know, all our communities, all our hospital systems, you know, we're trying to do this most efficiently. We're trying to keep our expenses down, but improving our patients' outcome is always first and paramount. And in the end, you know, the extra blood that would be used in if you were to adopt a more liberal approach in acute MI is a pretty small amount of extra expenses for an institution of this size. It won't be that impactful. And I think what matters most is that these patients do better clinically. And when patients do better clinically, they almost always cost less money because they're more or less likely to come back, into the hospital and have other complications. So that's always a secondary consideration. Just do what's best for our patients.
All right. And then finally, want to ask you, you're an actively practicing clinician as well, right? What is your approach to seeing the variations in your patients? Do you follow strictly the study that you've authored, or do you go off of it? Where do you sort of modulate your clinical practice based on data?
Yeah. So the way I think about this is the trial data gives us an average effect in a population. And I take that data as my starting point, and then I look at the patients, and I'm looking at them individually, just like I emphasized a moment ago. How are they feeling? What are their signs? What are their symptoms? What's their blood pressure look like? What's their pulse look like? What's their underlying comorbidity? What's their their personal preferences? And then I factor all into that as to what I do. It's a subjective way of there's some subjectiveness to this, no doubt. So we call it clinical judgment, right?
Right.
We call it clinical judgment, and we all try to do the very best for our patients. But I start with the trial data, and then I refine what I do in an individual patient based upon their circumstances.
So that would be the advice I would give someone else who asked me, and if they're in a conundrum regarding the situation.
Yeah.
What's next?
We have another grant from the NIH in which we're looking at patients with pre-existing cardiovascular disease. So the way I characterize these patients is, one is patients with acute MI. The second group is patients undergoing cardiac surgery. And then probably the largest group are patients in the middle who have some evidence for pre-existing cardiovascular disease. And the question is, how should you transfuse those patients? The cardiac surgery ones, you can let them go low, right, to 7.5 in the trials. In the MI setting, I think the trial data suggests that you should keep them higher. Now, what about this other group? So we're going to be doing an individual patient data meta-analysis in which we're getting all the trials, as many trials as we're able to get, that enrolled patients in the transfusion thresholds comparing liberal and restrictive. And we're going to look at those patients who have underlying cardiovascular disease and compare them to patients without cardiovascular disease and see whether liberal or restrictive transfusion strategy influences their outcome. So that's
Awesome.
that's our next project, and we're hard at work on that. And hopefully we'll have some results for you in a couple years.
And that will apply to my field,
Yes.
clinically.
Yes, for sure.
Looking forward to it. Thank you very much, sir.
You're welcome.
All right.